Okay. Okay. Hello everyone. Welcome to the White Army special session Surgery Simplified on Whipple's procedure. The White Army is privileged to have Dr. Prashant Shukla sir, senior resident in PDU Government Medical College Rajkot as our mentor today. We are honored to have you with us, sir. A very warm welcome to you.
Good evening, everyone. Today we would be discussing Whipple's procedure. I don't know how many of you are in the UG and the you currently undergoing UG program or in the PG residency, but I have kept it very simple for the UG students as well as first and second year PG MS General Surgery or DNB General Surgery students. So hope you all enjoy. So from the start, first thing we would be discussing here is the preoperative workup and the management of a patient who is planned for a Whipple's. So what exactly is a resectable pancreatic cancer? Resectable pancreatic cancer is defined as a pancreatic tumor without evidence of involvement of the superior mesenteric artery or the celiac artery, and no evidence of distant metastasis. So here we just need to rule out the involvement of the SMA or the celiac artery to make it to tag it as a resectable pancreatic cancer. So we should be very clear that venous involvement like portal vein or SMV is not a contraindication for surgery, and it does not preclude an R0 resection. Historically, it was a dictum that all the vessels like the SMA, celiac artery, say, portal vein, SMV should be free for the planning of a Whipple's procedure. But now it is not dictum nowadays. So, what is the perioperative management of a patient undergoing Whipple's? We have to plan the surgery in such way that the patient develops minimal complication because it's a kind of a supra major surgery. So, specifically, we need to focus on the perioperative anticoagulation to prevent the DVT for prophylaxis, and it can be done through low molecular weight heparin and the compression stockings. And then antibacterial prophylaxis is also indicated through cefazolin antibiotic, and antibiotic prophylaxis is not indicated beyond the first 24 hours of surgery. Now, as we know that we are going to resect the head of the pancreas, and and pancreatico-enteric anastomosis is supposed to be done. So, and it is the most critical part of this procedure, and reduce the complications from the failure of this anastomosis, we can plan to give octreotide to the patient because it decreases the pancreatic exocrine secretions and increases the chances of the pancreatico-enteric anastomotic leak. In some patient having a periampullary carcinoma with a very complete biliary obstruction may develop a very high bilirubin, like in the range of 15 to 20 milligram per dl. And in such cases, the preoperative biliary drainage should be done only if there is a preoperative cholangitis or it's a borderline resectable cancer and we plan to give preoperative chemotherapy or radiation. Finally, as we all know, due to the advancement of the imaging techniques, we can assess the resectability of periampullary carcinomas. But still, there is some role of staging laparoscopy because on the preoperative imaging, we can't be able to detect the peritoneal and the omental metastasis. So if the patient is having a CA 19.9 levels high, and on imaging we are pretty sure that there is no involvement of peritoneum or the omentum, so still we can plan for staging laparoscopy. There is also something called ERAS pathways, which were initially developed for the colorectal surgeries, but now they are also being followed for the hepatopancreatic biliary surgery, especially Whipples, in which we plan for early discharge of the patient through less post-operative fasting and early oral feeding post-operatively. So coming to the indications of Whipple's procedure. So the most common indication would be the pancreatic ductal adenocarcinoma, that is the CA head of the pancreas, IPMN, that is the intraductal papillary mucinous neoplasm, neuroendocrine tumors of the head of the pancreas, and the periampullary neoplasm. The last two indications on the right side, that is the trauma Whipples and the Whipples for chronic pancreatitis, used to be an indication for Whipple's procedure, but nowadays trauma Whipples is considered too much for a patient who requires a Whipple's procedure in the setting of trauma, and damage control protocols are followed in such patient. And in chronic pancreatitis, Whipples is considered to be a too aggressive and too supramajor surgery, and in such patients we usually prefer procedures which involves head coring and the decompression of the main pancreatic duct, such as Frey's procedure. So this operation has three distinct phases: the exploration and assessment, resection, and reconstruction. So we will gradually take all these three phases and see how it goes. So coming to the extent of the resection, in this figure we can see that the resection in a Whipple's procedure is done at three different segments of the gastrointestinal tract. At the it is in a classical Whipple's it is done just proximal to the pylorus. That is, we resect at the gastric antrum. In the biliary tract, we do the resection just proximal to the insertion of the cystic duct into the common hepatic duct, as close as to hilum as possible. And finally, we resect the jejunum 10 centimeter from the DJ junction. Here we can see all the three resections. So after we have explored, we have done the exploration, we have exposed the peritoneal cavity, we have to reassess the tumor, and we have to be very sure that is it resectable or not. So findings contraindicating resections are liver metastasis if of any size, which was not seen on imaging, celiac lymph node involvement, peritoneal implants, hepatic hilar lymph node involvement. These are the contraindicating. These are the points which contraindicates resection. Findings which not contraindicate resection when found on perioperatively are invasion at the duodenum or distal stomach, involved peripancreatic lymph nodes, involved lymph nodes along the porta hepatis that can be swept down with the specimen. It means if there is involvement of the hilar lymph nodes, that is a contraindication for resection. But if it is some distance away from the hilum and it can be resected with the CHD, then we should go for the surgery. So we have already used this term resectable, unresectable, borderline resectable quite a few times in our presentation. So we should know what this term means. So resectable means there is no tumor contact with the lumen of the vessel. Okay, and what then there are two words, that is the abutment and the encasement. Abutment is involvement of the vessel less than 180-degree, and the encasement is more than 180-degree. So abutment is borderline resectable. What does this mean, borderline resectable? Borderline resectable, that this cancer is upfront resectable, but it would be difficult for to carry out R0 resection in this patient, So we'll plan for a neoadjuvant chemotherapy, and then we'll reassess the patient and plan for an R0 resection. In unresectable cancers, it can never be resectable even after using neoadjuvant chemotherapy. So coming to the 6 key steps of the pancreaticoduodenectomy, that is the classical Whipples. So first will go into the peritoneal cavity. We'll do a laparotomy. Will focus on the exposure of the infrapancreatic SMV. We'll do an extended Cocker's maneuver. We'll go for the portal dissection. Then we'll transect the stomach. We'll do the enterectomy. Then we'll transect jejunum and dissect ligament of Treats, rotating duodenum under mesenteric vessels, and then the transection of pancreas and complete retroperitoneal dissection by removing specimen from SME and SMA is done. So, technique. So incision would be upper midline initially. After we have make sure that there is no contraindication for the resection. That is on exploration. There is no evidence of peritoneal or the celiac lymph node metastasis or liver metastasis, and the specimen can be easily resected out completely with R0 margins. Then we'll further extend the incision. Then we perform a white Cocker's maneuver at the level of aorta. That is on from the right side, we have to elevate the duodenum till we are able to visualize aorta. Then something is called artery first approach. Initially, when there was not very sensitive imaging techniques available, then we were not able to identify free fat plane between the vessel and the tumor mass. So we used to first mobilize the duodenum, and then we used to identify a plane between the pancreatic mass and the SMA, and if that is present, then only we used to proceed further. But nowadays, when we have a very sensitive imaging techniques, this is usually not recommended. So after we have made the incision, we have made sure it is resectable, we have to assess the lesser sac. Lesser sac can be assessed in two ways: by the division of the gastrocolic ligament, which results in the ischemia of the distal omentum, as the branches of the gastric epiploic arcade are divided. This is commonly done by in the usual common day practice, but the preferred method is to lift the momentum of the transverse colon and the mesocolon to enter the lesser sac. The benefit of this technique is that momentum can be used to cover the pancreatic and biliary anastomosis, and pancreas that and the momentum remains viable as the vascularity is not hampered. So coming to the SMV exposure. So after the laparotomy, we mobilize the ascending colon and the hepatic flexure towards the midline, and after which we trace the SMV. We ligate the vessels from the jejunum and the transverse colon, which drains into SME, and we should be able to identify that it is free of any tumor involvement. As we know, then we do a wide Coker's maneuver. In a wide Coker's maneuver, we elevate the duodenum from a plane from the retroperitoneum, and we should mobilize the duodenum till we are able to see the origin of the left renal vein. During mobilization, we can injure this two structure on the right side, that is the right ureter and the right gonadal vein, which we can see in the diagram. So what is this tunnel of love? Tunnel of love is nothing but it's a tunnel behind the neck of the pancreas between the pancreatic tissue and the underlying visceral vessels. This just precludes R0 resection and it makes sure that all the lesions has been resected and nothing is left behind. So, the tunnel of love is something very synonymous with the SMA first approach, in which adequate cauterization to facilitate assessment of the retroperitoneum and the relation of tumor to vascular structures. After we have made sure that the resection can be done with the SMV, SMA, celiac artery are free of any tumor involvement, then we go to the dissection at the porta hepatis, in which here we are supposed to identify the origin of celiac trunk. It branches the here the first the gastroduodenal artery is resected and divided, and then we approach the porta hepatis region, in which we resect the CHD, that is the common hepatic duct, close to hilum and distal to the insertion of cystic duct. After this or before this, if the surgeon prefers, then we will do the resection or dissection of the cystic plate and ligate the cystic artery to for a completed cholecystectomy. Now, in this, after the resection of the porta hepatis has been done, we'll do the resection of the antrum. Here, mainly two vessels are important, which should be tackled down very carefully. That is the left gastric artery and the vein, and because they run along the border of the lesser curvature, and they can bleed profusely if not managed properly. On the greater curvature, we have the right gastroepiploic artery and vein, which should also be ligated and dissected. Now, after the antrum has been resected, we come to the jejunum. After the thorough dissection of the ligaments of treats and the freeing of the retroperitoneal duodenum, that is the third and fourth part, we resect the jejunum 10 to 15 centimeter from the DJ junction. Now, as we have resected the pylorus, we have resected the biliary tract close to the hilum, and the jejunum 10 centimeter from the uh, DJ junction. Now we want to get the specimen out. So we create a we elevate the neck of the pancreas from the retroperitoneal attachment. We should be aware that there are lots of vessels which drain from the posterior border of the pancreas into the portal vein, splenic vein, and the SMB. So we should be carefully ligating them, and then we free the posterior pancreatic parenchyma from the retroperitoneum. After this has been done, there should be free space between the visceral vessels and the pancreatic parenchyma, as we can see in this right-sided diagram. And after thorough hemostasis, we further elevate the specimen towards the right side, so we can ligate all the vessels which drain into the portal vein and SMB from the head of the pancreas, specifically inferior pancreaticoduodenal vein, and then we transect the pancreas with a stapler. Now we plan for the removal of the pancreaticoduodenectomy specimen. Here we should be very careful, as I already told, the inferior pancreaticoduodenal vein is quite tricky here, and near the completion of the resection of the pancreas from the retroperitoneal attachments, the inferior pancreaticoduodenal artery is also comes, which is a branch of superior mesenteric artery. So coming to the vascular resections, so we can resect portal vein or superior mesenteric vein and use a graft and maintain the continuity. But in case of SMA, it is not possible. So involvement of the superior mesenteric artery is a complete and absolute contraindication for surgery. In some cases, we may have gastric metastasis, involvement of the right border of duodenum, and this all does not preclude resection, and we should go for multivisceral resection, and the goal should be attain a R0 resection. Initially, we used to do extended lymphadenectomy along the border of the along the border of the common hepatic duct, peripancreatic lymph nodes, and the gastric lymph nodes. But now we know that there is not much survival benefits, and it further increases the morbidity to the patient. So it's not commonly used done nowadays. So coming to the, we have completed the two phases of the Whipple's procedure. Coming to the last phase, that is the reconstruction. Reconstruction after pancreaticoduodenectomy involves three anastomoses mainly: the pancreaticojejunostomy, hepaticojejunostomy, and the gastrojejunostomy. So in the pancreaticojejunostomy is the major cause of procedure-related death. And to describe a PJ, we have to use this adjectives, that is, it is done in a duct to mucosa, end to end, end to side fashion with a retrocolic jejunal lymph. We will know the meaning of all these three terms, that is the duct to mucosa, end to side, and retrocolic gradually. So, as we all know that we have to do the anastomosis of the leftover pancreas and make it drain into the jejunum. So, first we take few stitches from the seromuscular jejunum and the pancreatic parenchyma to make it hold and stay with the jejunum. Now we have to do a duct to mucosa anastomosis. Usually the diameter of main pancreatic duct around the level of neck is around 5 mm. It can be more, it can be less, but in most of the cases it's around 5 mm. So to ease the anastomosis after fixing the posterior parenchyma with the jejunum, we take stitches from the anterior border of the main pancreatic duct, and then we uh, we go for the posterior fixation. After we have made the anastomosis of the jejunal mucosa and the main pancreatic duct. We fold the anterior pancreatic parenchyma towards the jejunum with few seromuscular stitches. The goal of this stitches that after we have fixed the jejunum with the pancreatic parenchyma, the duct to mucosa anastomosis should not be visible. So this is the completed pancreaticojejunostomy, in which we are not able to see the duct and the mucosa, and the parenchyma of the pancreas is well fixed to the jejunal border. Coming to the bilioenteric anastomosis. Bilioenteric anastomosis is done, it can be either done through continuous or interrupted technique, and 40 PDA sutures are used. So, while doing the hepaticojejunostomy, it is better to take posterior sutures first, as because as we were able to do the anti stitches in the PJ, will not be able to do the anti stitches here. So we take few stay sutures and first do the posterior anastomosis. After that, we pass few interrupted sutures from the anterior border, and we complete the hepaticojejunostomy. So finally, you can see that hepaticojejunostomy is done like this. The posterior fixation is done first, and then the anterior fixation is done. So coming to the reconstitution of the gastrointestinal continuity, it is done in an anticolic end-to-side gastrojejunostomy, about 50 centimeter downstream from the hepaticojejunostomy, and use the transverse colon and omentum to shield the anastomosis away from the PJ. So it is constructed in a usual classical two layers using monofilament absorbable 3.0 PDS sutures in a continuous fashion. So there is nothing special about the gastrojejunostomy part. And after completion of the reconstruction of a Whipple's procedure, we can see how it is done. So we have a PJ here, a hepaticojejunostomy here, and a gastrojejunostomy here. So finally coming to the completion of the procedures, so we can use the abdominal drains and the nasogastric tubes. The drains usage of drains is completely at the discretion of the surgeon, and it should be removed when the drain amylase is absent and output is less than 20 ml per day. NG tube is removed on the post-operative day one, and as per ERA's protocol, the oral feeding should be started as soon as possible. So, complication of the Whipple's procedure. Uh, whenever there is a anastomosis, there is always a risk of leakage. So here can be a leakage from the pancreatic anastomosis or biliary anastomosis, which can lead to post-operative sepsis. As we will be manipulating a pancreas so much, so it can lead to acute pancreatitis. Then it can, and there can be a case of hepatic failure due to increase serum bilirubin preoperatively. Post-operative hemorrhage is usually due to erosion of the ligated gastroduodenal artery stump. And finally, there is can be post-operative gastric bleeding from the mucosa and thrombosis of the superior mesenteric artery or vein. So this ends our presentation. Thank you.
Sir, there was one doubt, sir.
Okay.
Can you explain the artery first approach once?
Okay. Yeah. Actually, the SMA first or the artery first approach was done previously because we were not able to assess the involvement of the SMV and the SMV and the portal vein in the preoperative imaging. But now we have better angiographic techniques and everything like that. So we have a pancreatic protocol CT now available. So it delineates a plane between these visceral vessels and the tumor mass and the pancreas. So nowadays we are able to appreciate a fat-free plane posteriorly between the pancreatic tissue and this visceral vessels. But initially it was not possible. So initially what the surgeon used to do that as soon as they entered the abdomen, they used to do a Cocker's maneuver. They used to put the finger between, they used to elevate the duodenum with the head of pancreas anteriorly. So they were able to see a plane between the pancreas and the SMV portal vein and SMA. This used to make sure that this resection is possible. Otherwise, nowadays, what we do, if we are confident on the imaging, we proceed with the mobilization of the right colon, and we then we do a Cocker's maneuver. And then, because we are sure that it's nothing is involving this visceral vessel. Hope you have understood.
Yes, sir. Thank you,
Yeah,
sir.
yeah,
I'll check for any other doubts on YouTube.
yeah,
Sir, I have a question.
yeah.
The pancreatic jejunostomy, uh, what suture material we have used, sir?
Uh, for any GI anastomosis, there's lot of suture materials which are available, and there is a lot of school of thoughts. The ideal is PDS, but we don't preclude, or we don't will not say it is wrong to use Vicryl or silk. So in many setups we are using Vicryl also, and we are using Selk also. But ideal is PDS. We can
Okay.
use all the three sutures.
Sir, but due to the pancreatic enzymes, it won't be get digested, Vicryl.
Y-
So the chances of leak will be more.
yeah, it used to be said like that, but I hope you know that there's a tensile strength, and the absorbability of the PDS is around 90 days. So it is considered quite a strong suture which can hold the pancreatic secretion, because what in many studies we have seen that if there is leak of PJ, then proline is also not very safe suture. It also get digested. So ultimately, no suture can prevent your anastomotic leak. It's the technique which you do safeguards the pancreatic jejunostomy leak.
Okay. Thank you, sir.
Yeah.
Sir, that's all. There were no other doubts, sir.
Oh, okay.
Thank you so much, Dr. Prashant, sir, for
Yeah.
such a wonderful, detailed explanation about the Whipple's procedure. We could
Yeah.
get to know a lot of things because of your lecture.
Okay, sir.
Uh, we could understand in detail, and thank you for making surgery simplified, sir.
Okay.
Uh, I thank all the attendees for their active participation, and thank you one and all.
Thank you so much.
Thank you.